Among all the cases that we have seen in our experience, this one is particularly interesting. This patient is a 65-year-old gentleman who is diagnosed incidentally with the left renal mass. This mass is originating at the lower pole of left kidney. This mass is in particular configuration in such a way that this mass is engulfing the ureter, the upper ureter, on the medial border. There is a thin layer of the mass itself which is covering the upper ureter just after the PU junction. So, per se, the mass in itself looks like a partial nephrectomy could be performed. But then, to do a partial nephrectomy in this case would make us cut open the mass, and that would breach the oncological safety. So, a shared decision was taken to perform a radical nephrectomy. The opposite kidney of this patient was absolutely normal, and patient is a thin lean case with no comorbidities. So, a decision was taken to perform a left side radical nephrectomy laparoscopically. Standard ports are being placed, and the pneumoperitoneum was created by Very's needle, and the dissection will proceed as any standard radical nephrectomy. The initial steps are the same. Uh, the dissection proceeds with an incision just medial to the line of Tolt, and a plane is developed between the mesocolic fat and the gerotus fascia. It is of particular importance that gerotus fascia should not be opened in a case of radical nephrectomy, and this avascular plane should be in absolution. This here, the plane is being developed, and the dissection will proceed just between the mesocolic fat and the gerotus fascia. The plane between the gerotus fascia and the mesocolic fat should proceed in its entirety. The splenorenal ligament is being incised here, and the spleen should be mobilized uh, well medial, so that the upper pole of the kidney can be dissected appropriately. We definitely want to separate the adrenal gland here. Removal of adrenal gland is not necessary in every case of a radical nephrectomy. In this patient, the tumor is a lower polar tumor, and the adrenal gland is particularly normal. There are a few indications in which adrenal gland can be removed, like in upper pole tumors, like when the adrenal gland is infiltrated with the tumor, a plane cannot be developed between the upper pole of kidney and the adrenal gland. So here we are particularly planning to spare the adrenal gland. Here in this frame, we can see the neovascularization that comes with the renal masses. They are particularly vascular with various growth factors and angiogenesis in these tumors. One should be very careful to dissect away from these neovascular areas. These vessels tend to bleed very profusely. If ruptured or any mistake happens, then it gets really difficult to control the bleeding, because these channels are not in a regular direction. They are haphazard in manner and can bleed very profusely. Now the psoas muscle has been identified, and we would want to walk over the psoas muscle, and the gonadal vein and ureter are lifted with the fat above, and the fat in this golden triangle area is not breached at any place. We would want to keep this covering completely intact. Below we can see the left side common iliac artery, and above here we have the ureter-gonadal complex. We have separated the ureter and the gonadal vein here. Now we are approaching towards the hilum, and to reach the hilum, we typically follow the gonadal vein, which drains into the renal vein, and this helps make the dissection easy. We had preemptively studied the CD scan with contrast thoroughly. This patient has a single renal vein and a single renal artery. Now here we are doing the dissection bluntly with the help of a suction. Suction is a great instrument to dissect the hilum, and it sucks out all the fat between the fibrous tissue, the lymphatics, so that the structures can become visible. Now this blue colored appearance is the renal vein right here. So the fat is being dissected away from the covering above the renal vein. Here we can see the renal vein properly, and the fat is being dissected away from it so that the vein can be encircled and clipped later on. This vein above the renal vein, which is draining into it, is the adrenal vein. So we'll first handle the adrenal vein and then go ahead with the dissection. So, right angle instrument is being inserted, and the adrenal vein is being dissected uh, from behind so that it can be clipped. Now, two clips will be placed, one towards the patient side and one towards the adrenal side, so that it can be cut in between. There is a thin lumbar vein draining into the renal vein also. So we'll clip it and cut. And there are few lymphatics which are running over it. Clipping this vein is very important because only after clipping and cutting this vein will enable us to go behind the renal vein so that the renal artery can be dissected. So now a fourth port is being placed. This will help us retract the kidney uh, laterally so that we can easily dissect the hilar area. And renal artery dissection is particularly a very careful area to dissect. It has a lot of lymphatics around, and they are, if injured, bleed very profusely. The renal vein here is being encircled. A right angle instrument is being inserted behind the renal vein to encircle it so that later it can be clipped well. This area is showing very high pulsation. Most likely, the renal artery is behind this fat. So, we are turning our attention to dissect this area. A hook is a very good instrument to work around here. The lymphatic strands can be cooked very well, and the artery behind it can get in view. So here the renal artery is dissected and it has come in view. The artery is appearing very high bulging, and we are suspecting some atherosclerotic changes and plaque in it. So we'll try to move around the artery to dissect it well. All the lymphatics should be cleared and sealed well to prevent the lymphoria later on. We want to take the lymphatic around the hilum only. We There is no role actually for a lymphatic dissection in a renal tumor. There is no proven role as such for a lymph nodal dissection. So para-aortic lymph nodes particularly are not dissected in a renal tumor, but at the same time, the hilar lymphatics they do definitely have some role in renal tumors. So, for the staging purposes, hilar lymphatics are taken along with the specimen in radical nephrectomies. So, during the dissection, what we can do is we can directly keep the lymphatics towards the specimen, and rest para-aortic lymph nodes are dissected downwards. So here we are applying a metallic clip just to reduce the flow in the kidney and the tumor. Yeah. So while applying the metallic clip, we could feel the resistance of this atherosclerotic plaque that could be possibly within the artery, and that made us apply the clip with some difficulty. But hemolock clips definitely are more secure and have a proper seal lock over the artery stump. Now we want to separate the adrenal gland from the renal upper pole. To identify this groove, this plane between the upper pole and the adrenal gland, while retracting the kidney downwards, we can see an indentation between the adrenal gland and the upper pole of kidney. So we can just walk between this upper pole and the adrenal gland. If we lose this plane, the adrenal gland can definitely bleed very profusely. Another way of finding this plane is dissecting just above the renal vein and walking into the plane between the upper pole and adrenal gland. There can be a few arteries coming from the renal artery towards the adrenal gland, as it has a three directional blood supply. So this dissection should be done very carefully. So here we have separated the adrenal gland completely, and then we'll move towards the hilum. The lymphatics behind the renal vein is giving us some difficulty in applying the clip, and a lymphatic strand was caught in this clip. So we decided to move a little proximal to apply more secure clip in this case. So more proximal dissection has been done, and proximal clipping of the vein was done here. Then to apply the distal clips, the vein was splitting into two just at the hilum. So we decided to separate and apply separate clips at the specimen side. So here we are applying two separate clips on these branched renal vein, and the renal vein will be cut in between. Another clip at the renal artery or towards the specimen side, and it will be cut in between. See, as expected, the renal artery is showing a plaque inside. Another clip at the lymphatics to prevent the lymphatic leak, and the specimen will be separate from the hilum. Now the gonadal vein and the ureter has been clipped. So we'll apply another clip and cut in between. This will complete the nephrectomy, and then the specimen will be mobilized all around. The mobilization of specimen is also important here because we do not want to breach the gyrotous fascia and the fat spillage from within the gyrotous fascia. So we move in an avascular plane around the gyrotous fascia. The specimen is being mobilized here, and the upper pole was particularly difficult in this case. Although the adrenal gland was previously separated, but still the fibers attaching the upper pole area was pretty difficult. So here, the complete radical nephrectomy has been performed. Intact gyrotous fascia, the ureter enclosed in it, the gonadal vein within, and nowhere the oncological barriers have been breached. Now we are holding the specimen at the ureteric end, and now we'll start the extraction of the specimen. उठ के निकाल दिया ऐसे मत करो, ऐसे मत करो। एक माप में देखो। इन दोनों को निकाल दो। While the closure is being performed, I have a habit of cutting open the specimen to see the interesting findings and correlate what I saw in the CT scan. So the specimen was bivalved here, and the pelvic ileal system is being cut open. Now I want to see where is the tumor and how the morphology of the tumor appears like. These are the calyces, and that's the pelvis, and this is the ureter. Now I want to further cut open the lower pole and in such a way that the tumor also gets bivalved. Here the ureter is appearing. Now as I cut open the tumor in its center, see how the yellowish appearing tumor with a glistening center. This here is the tumor complete. And as I put my artery forceps, you can see the tumor is going, or say, engulfing the ureter. Thank you for watching. To see more such videos, subscribe to my channel.